This video looks at some of the general surgery for pediatrics diseases that are high yields for your surgical shelf. Much like the one that was just before this, peds hours to days, this one, peds days to weeks, is going to be a hodgepodge of high yield topics that are covered in greater detail in pediatrics. This video should be watched only for your surgical shelf. Let's go through a disease, each one at a time. The first disease I want you to know about is necrotizing enterocolitis. Necrotizing enterocolitis is a disease of premature infants. So if you see a GI problem in the NICU, it's necrotizing enterocolitis. The patient is going to present with a bloody bowel movement. The diagnosis will be made by getting an X-ray, a babygram. And what you're going to see is air in the wall of the intestine. The test is probably just going to say pneumatosis intestinalis, which means air in the wall of the intestine, only in Latin. If you see this disease, you have to go to immediate bowel rest. But baby is still growing and is in need of nutrients, so you're going to start total parenteral nutrition. And because bowel is dying and bowel is not sterile, you need to put them on IV antibiotics. And you're going to choose antibiotics that cover gut flora. Some babies can get through this without surgery, but those kids who worsen or fail to improve with conservative management will need an operation. And generally, you just go cut out the bad segment. If you see necrotizing enterocolitis, the other thing you have to do besides treat it is recognize the other diseases of premature infants that can arise. We'll talk more about these in the pediatric course. Necrotizing enterocolitis, intracranial hemorrhage, bronchopulmonary dysplasia, and retinopathy of the newborn. So those diseases that you should not engage for surgery are covered in more detail in pediatrics. The next disease is a meconium plug. And a meconium plug effectively means cystic fibrosis. And so the test has to do one of two things. They either have to give you someone who's had a prenatal screen, because we assume that everyone in this country gets prenatal care, and therefore they know walking in this kid has cystic fibrosis. Or they'll give you a reason for why there was no prenatal care at all. And they do that in the way of an undocumented immigrant or someone who just recently moved from another country who didn't know they were pregnant or something of that nature. It has to be extreme and egregious that they have not had prenatal care on the test to let you know that they don't have a screen, because everybody gets screened for cystic fibrosis. The patient is going to present as a failure to pass meconium. And because this is effectively a bowel obstruction, it may also present with biliary emesis. Now, if you remember from the last video, we did not include this under differential for biliary emesis. The reason why we didn't do that is because in the topic of biliary emesis, they're going to give you a double bubble sign, and they want you to choose between the other diseases based on the X-ray pattern. It's going to come at you differently in meconium plug. You're going to have failure to pass meconium. If you get an X-ray, you might be lucky enough to see a gas-filled plug. Usually you don't see this in life, but on the test, an X-ray that shows a gas-filled plug in the setting of failure to pass meconium, the diagnosis is meconium plug. But why this question comes up on the test so often is because a diagnostic step is also therapeutic. Use a water-soluble contrasted enema. The idea is that cystic fibrosis in the disease, it cannot excrete enough water into the lumen. And so the plug forms because it gets really hard and dried out. If you give water-soluble contrast, well, basically you dissolve the plug and the disease is resolved. The treatment is water-soluble contrast enema. But because it represents cystic fibrosis, you're also going to have to treat the cystic fibrosis. We talk more about this in pediatrics lower airway. the things you have to be concerned with is absorption for pancreatic enzymes, replacing fat-soluble vitamins, A, D, E, and K, pulmonary toilet, and prevention of infection. And just for that 290, I'm not putting it on the board, they can have a perforation leading to meconium peritonitis, which is a surgical emergency. Hirschsprung's disease is a board favorite because there's so much they can ask about it. So you have to know a lot of little details and the ifs and thens. Hirschsprung's disease is a failure of inhibitory neurons to migrate to the distal colon. I'm running it all on the board on purpose so that you can read it over and over again. In the embryologic environment, these inhibitory neurons have to migrate and then innervate the colon. In Hirschsprung's disease, the distal portion of the colon fails to get innervated by inhibitory neurons, which means it cannot relax. The distal part of the colon is always affected. The proximal colon is always innervated. And the severity of the disease is going to be determined by how far the neurons got. There will be absent neurons, so there will be no Auerbach plexus. There will be no myenteric plexus. The patient is going to present in one of two ways. It is either going to be severe enough so that there is a failure to pass meconium in the first 24 hours, or there is going to be not that severe disease in the way of most of the colon is innervated, and therefore they'll reach toddler age where they'll then begin to have trouble with toilet training, having overflow incontinence. If you get an X-ray, what you're going to see is a dilated proximal colon. Then you're going to get a transition point and get normal looking colon to the anus. It's normal looking, but bad colon. The proximal colon looks dilated, but it's actually good colon. This becomes important when you decide to do surgery. The diagnostic step is going to change based on whether or not you have that neonate with failure to pass meconium, severe disease, or you have that toddler with overflow incontinence. The first diagnostic step is the X-ray. The second is going to be, if you have failure to pass meconium, what you want to do here is a contrast enema. What you're going to see is the dilated colon, the transition point, and the normal looking colon. That's what you expect, same thing as the gas pattern on the X-ray. If you are that toddler, then what you're going to do is use anal manometry. There are inhibitory neurons that are missing, and therefore it will be constant tone. The best test is a biopsy, which shows you the path of absent Auerbach plexus, absent myenteric plexus. The treatment is going to be surgery, but you want to make sure you remove the bad colon only, which is the bad colon looks normal. The reason why you have different presentations is because the proximal colon is working fine. It's pushing, trying to get stool out. The bad colon wants to get things out, but it hasn't been able to relax to accept any stool to expel. So if you have severe disease, it doesn't matter how hard the proximal colon is pushing, if there's too much bad colon, it can't overcome it. If, however, you do a digital rectal exam and relieve that constriction for a moment, you will have explosive diarrhea. Explosive diarrhea after a digital rectal exam on a neonate is Hirschsprung's. But overflow incontinence can happen in a toddler, whereas they have enough good colon to overcome the resistance of the distal colon until they don't, and then they get constipated and they have a fecal impaction, but they get liquid stool around the impaction, leading to overflow incontinence. When you do surgery, remove the bad colon, which is the normal looking colon on your diagnostics. Intussusception, bonus points if you can spell it right. I usually don't. Intussusception is caused by telescoping of the bowel. What does that mean? So you've got a normal bowel, and on the edge you've got this blood vessel running along with it. And what happens is that a segment of bowel just pushes its way into the lumen of the preceding bowel. Looks like this, where this bowel has kind of pushed its way into this. Now you still have your blood vessels running on the outside, and so proximal to the intussusception, no big deal. You still have blood vessels running on the outside, so distal to the intussusception, no big deal. The problem is in this area where the vascular supply is basically being cinched down on, and you are losing blood flow to that segment. Gut's going to die, that's no good. In kids, 90% have no lead point. If you compare that to adults who get intussusception, there's almost always some lesion, like a malignancy, that leads to intussusception. In kids, it just happens, and you don't have to be very aggressive about finding if there's a lead point or not. The patient is going to present with a sudden onset abdominal pain. But they will find out very quickly that the fetal position makes them feel fantastic. They will be curled up in a ball with their knees to their chest. Knee-chest position relieves the pain. If you see on the test a sausage-shaped mass, they are telling you it is intussusception. If you wait long enough and the bowel dies, there could be current jelly diarrhea. The current jelly diarrhea is the infarcted bowel that has died and sloughed off. You want to intervene before that happens. In a similar vein, if you did the x-ray, which you should do, you might see some late-stage findings. But it's late-stage findings because the bowel is already dead. What you want to do instead is use an air contrast enema, which is both diagnostic and therapeutic. Again, the enemas are the things that make these key fodder for the test. It's very clear to identify they're having intussusception, and you need to know to do the air contrast enema as opposed to another test or surgical intervention to fix it. Pyloric stenosis is another one that has a very classic presentation with a major pitfall. Pyloric stenosis is effectively a gastric outlet obstruction. The patient is going to present with projectile vomiting. And the things they're going to give you in the vignette that say, hey, this is pyloric stenosis, is going to be firstborn male, visible peristalsis, and an olive-shaped mass. Extremely easy to spot on the test. Now I'm going to explain the disease and then the pitfall. In pyloric stenosis, you find the visible peristalsis and the olive-shaped mass. The diagnostic step to diagnose pyloric stenosis is an ultrasound that shows a donut sign. And having identified pyloric stenosis, you need to fix it. So you do surgery, a pyloromyotomy. But that's how they're going to get you on the test. You're going to pick ultrasound for donut sign, or you're going to try to do surgery. What you must do is find out if there are electrolyte abnormalities because it's a gastric outlet obstruction and baby's been vomiting. What you need to do is get a chemistry, a BMP, Chem 7, whatever, some way of looking at electrolytes. What you're likely to see is because they're vomiting up a bunch of acid is a hypokalemic, hypochloremic metabolic alkalosis. If you see that, don't do the ultrasound or pyloromyotomy. Skip to give fluids and admit. Replace electrolytes. The idea here is you have to save baby before you operate. And this is where they're going to get you on the test because it is so easily spotted, but people forget about the electrolyte thing. Biliary atresia is test fodder because of the diagnostic step you take. It's in the name, biliary atresia. You don't have development of a biliary tree. And so you cannot get conjugated bilirubin out of your system. And so it's going to present with a worsening or persistent direct hyperbilirubinemia. And it usually takes about 2 weeks for someone to notice. That is, at birth, they might have a mildly elevated bilirubin, but when they come back in for their 1 week or 2 week visit, they're yellow and they're not getting better. And you're going to sit there just trying to decide, is this breast milk, breast John, da, 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 da. You get the direct bilirubin and realize it's elevated. That's pathologic. You have to go looking. The diagnosis can be made with an ultrasound that shows no ducts. But that's not what they're going to want you to do. Biliary atresia is on the test because the way you make the diagnosis is with a phenobarbital HIDA-scan. You give phenobarbital for a week and then do a HIDA-scan. And what happens is that you're going to see in the biliary tree, you're only going to get contrast to the level of the liver, and it won't get into what's supposed to be there, the biliary tree to the duodenum, because that path doesn't exist. The surgery is named and sort of involved. It's in your notes. Just know that you have to cut out the atretic segment. Surgery is the answer. And the last one is choanal atresia. This is a problem with getting air from your nose to your pharynx. And again, the presentation is so clear that it's great board fodder. Because these babies can't get air through their nostrils to their throat because of an atretic segment, what's going to happen is when they latch to feed, they'll turn blue. They turn blue, they freak out, they cry, they unlatch, and begin breathing through their mouth again. That blue with feeding, pink while crying, is pathognomonic for choanal atresia. You might also hear snoring baby. Babies have not been around long enough to develop OSA, so the snore is probably indicative of some blockage from their nose to their throat. The diagnosis is made by passing a catheter, which fails to pass because it coils up at the atretic segment. You can do a flexible scope, but that's not necessary. And the treatment is surgical removal of the atretic segment, opening up the passage between the nose and the trachea. And so this video was a hodgepodge of the high-yield topics and some of the pitfalls you might encounter on your surgical shelf. Necrotizing enterocolitis, preemie, bloody bowel movement, conservative before surgery. Meconium plug, water, soluble contrast enema, follow-up with a diagnosis of cystic fibrosis. Hirschsprung's disease, gotta know everything on the board. Failure of inhibitory neurons to migrate, no Auerbach, no myenteric plexus. Failure to pass meconium with an explosive digital rectal exam is pathognomonic for Hirschsprung's disease. Or it could also be in a toddler having trouble with toilet training because of overflow incontinence. The x-ray will show you a dilated good colon, but a normal-looking bad colon. If they are an infant, do a contrast enema in order to make the diagnosis. If they're a toddler, use anal manometry. The best test is a biopsy. Treatment is surgical. Intussusception, sudden onset abdominal pain. Fetal position makes it better. Sausage-shaped mass. If you see those things, and you will, the diagnosis is done, you do air contrast enema, diagnostic and therapeutic. Pyloric stenosis, same thing, visible peristalsis and olive-shaped mass, it's going to be obvious. Don't forget about the electrolyte abnormalities, fix those first before you get your donut sign and pylori myotomy. Biliary atresia, phenobarbital, HIDA scan, you notice that there is an elevated direct bilirubin, which has gotten worse over time, and choanal atresia, blue feeding, pink crying, pass a catheter. That's pediatric general surgery, weeks to months. Become a better doctor. Subscribe now to get access to our premium content.